Hello friends, welcome to our YouTube channel Medicine Decoded. I'm Dr. Shonali Chandra and we are starting an MCQ session where we are going to take up MCQs on the topic that is primary amenorrhea. Now they have been asking a lot of questions on amenorrheas, primary amenorrhea as well as secondary amenorrhea. So we will have a look at many questions in the upcoming days. So let's get started with this topic and I will be taking up your doubts here and your responses here in the live chat, so you can give me your answers here itself. Now before we start the MCQ session, I just wanted to give you a very brief idea about how you should be attempting these questions. So let us get our basics clear from the very beginning. When we're talking about primary amenorrhea, you see, and attempting questions, we should focus on what they're asking us. They're probably asking us what is the reason, they are asking us the diagnosis, they're probably asking us what is the next step to make a diagnosis, or they are giving us a diagnosis and asking us what is the treatment modality. Now again, it becomes a very huge topic, but I want you to focus on the very basics, right? So the primary amenorrhea, the cause could be on the pituitary or hypothalamus, right? So there could be deficiency of gonadotropin releasing hormone, which we call as Coleman syndrome. There could be a pituitary tumor here as well. So there can be many causes, but on the offhand, yes, there can be pituitary and hypothalamic causes. There can be ovarian dysgenesis where the gonads are dysgenetic, right? And the most common cause of primary amenorrhea we all know is Turner syndrome, right? So this is a type of gonadal dysgenesis where there are streak ovaries, where there are other types of gonadal dysgenesis also, which you should keep in mind in your differential diagnosis. Another form of gonadal dysgenesis here is the Swyer syndrome, which is a 46XY type of gonadal dysgenesis. In Turner syndrome, the karyotype is 45XO most of the times, and X is missing, right? Then there can be outflow tract abnormalities like the uterus could altogether be absent, or there could be obstruction here at, there could be a transverse vaginal septum or an imperforate hymen, that is obstruction to the outflow tract. Plain and simple, clear-cut logic, okay? If there are outflow tract abnormalities, you see everything above is fine, right? So your hormone levels are going to be normal, right? In outflow tract abnormalities, FSH, LH and estradiol levels are all going to be normal. If estrogen levels are normal, you see, then the breast development is going to be present. Very simple, right? Now moving on, if there is pituitary or hypothalamic cause, or there is ovarian dysgenesis, whatever be the reason, ultimately because of these causes, what is happening, there is estradiol deficiency. So if there is estradiol deficiency, you see the breast development is going to be absent, right? Keep that in mind. Now next step, focus on the hormone levels and focus on the serum FSH levels, because in both the conditions, pituitary hypothalamic cause or ovarian dysgenesis, both situations estradiol is deficient, okay? But if there is a pituitary or a hypothalamic cause, you see signal from above is not coming, so your FSH levels are going to be low, okay? And if there is gonadal cause here, ovarian dysgenesis here, then estradiol deficiency is going to cause a feedback stimulation of the higher centers, and your FSH levels are going to be high. You remember this chart while attempting the questions further. So Muhammad Amir Khusru and PUBG Nights, interesting. Welcome to the class, and let's get started with the MCQs now. Now let's have a look at the first question of the day. There's a 14-year-old girl who's brought to you for evaluation of absence of onset of menses. History indicates that she has experienced, growth spurt at the age of 11. She has normal breast and pubic hair development that began approximately 3 years ago. She appears to be of appropriate height. She has no other medical conditions and does not take any medication. She is not sexually active. There is no history of cyclical abdominal pain. Per abdomen and local examination is also normal, and you can feel the uterus on per rectal examination. So uterus is also present. So when you look at it, Nothing seems to be wrong with this young girl. What is the most appropriate next step? Should you be ordering a hormonal profile? Should you be starting her on hormone replacement? Should you perform an ultrasound, or no treatment is required at this point in time? So what do you think is the best possible response here? Remember, she is a 14-year-old girl who's been brought for evaluation. She is only 14. At the offset, nothing seems to be wrong. You've done a basic preliminary examination. There is no high risk history. The uterus is present on per rectal examination. What is the most appropriate response? Well, right now she doesn't even fit the definition of delayed puberty or primary amenorrhea, does she? No treatment is required at this point in time. What is the definition of primary amenorrhea? What is the definition of delayed puberty? Have a look at this. This is the sequence of pubertal development. Growth spurt happens, then breast development, that is thelarchy, happens, then pubic hair development happens, then a peak height velocity is reached, and then the final event is the actual onset of menses, which we call as menarche. Right? Now, what we have to understand here is, if the breast development is proceeding fine, if the breast development is present, how long should we wait before we start evaluating this woman for amenorrhea? How long should we wait for menses to actually occur? Right? So if your breast development is present, then we should be waiting for about 15 years to label it as primary amenorrhea. And the other thing, if let's say breast development is not happening, that means that the sequence of pubertal development has stopped here. Then how long should we wait before we start evaluating this young girl? Then we should wait till the age of 13 years. And if she's beyond that and yet not achieved breast development, then we start evaluating for delayed puberty or primary amenorrhea. So get these definitions clear, they're very basic. So if you look back at the question, she's yet only 14 years of age with normal breast development. Nothing seems to be wrong. She does not deserve any further evaluation. We can't simply wait for another year before evaluating her any further. So at this point in time, she needs no treatment. You see, pelvic ultrasound is going to give you no other extra information. You've done a basic preliminary examination. The uterus is present and you can see that the breasts are normal developed. If breasts are developed, that means she is having estrogen in her body and her ovaries are functioning normally, right? Now, let's have a look at the second question. Now, this time there is a 16-year-old girl who's been brought to you for evaluation of absence of menses. History indicates that she experienced growth spurt at the age of 11. She has normal breast and pubic hair development that began approximately 3 years ago. She appears to be of appropriate height. She has no other medical condition and takes no medication. So same profile, okay? But now the age is 16 years. What is the most appropriate next step in the evaluation of this patient now? Go through the question, read it again. At the offset, normal breast and pubic hair development, growth spurt is also there. She's of appropriate height. That much information is given to you. What is the next step in evaluation? You want to do a hormonal profile, you want to do MRI brain, you want to do a pelvic ultrasound, or you want to do a pelvic examination. What is the next step in evaluation? Go step by step. Yes, normal breast development, meaning yes, I can fairly well assume that she is having normal functioning ovaries, right? She is having estrogen in her body. That is why breast development is progressing fine, right? But what I don't know as of yet right now is, does she have a uterus or doesn't she have a uterus? Okay, what is the problem? Is she having an outflow tract obstruction? Could that be a reason? Now that can simply be evaluated by doing a basic pelvic examination at the first step. Yes, of course, if she's a young girl, she might not be willing to get her pelvic examination done, she might not even agree to a per rectal examination, then you can do an ultrasound. But a basic local examination at least can be attempted and should be done, right? So a lot can be made clear by doing a simple pelvic examination, and that becomes the next step in the question. So Uma and Piyush, I agree with you that option number D seems to be the right response, right? Now understand here also that if you are looking for diagnosis, like now, how common is uterus being absent? It's not the most common cause. What is more common? Imperforate hymen is more common. And if you want to diagnose imperforate hymen, you just need to do a local examination. That's it, right? So why go ahead with an ultrasound unnecessarily when you're more likely to find an imperforate hymen even in this scenario? So go step by step while making diagnosis and answering and attempting such questions. Now, let's have a look at the next question. Now, this time she is a 15-year-old girl who's brought to the emergency with complaint of severe abdominal pain and acute urinary retention. Her complaint is not amenorrhea. She's been brought with severe abdominal pain and acute urinary retention. She has not yet attained menarche. That's another information that you get when you ask the young girl whether she is having menses or not. On local examination, there is a tense bluish bulge at the introitus. All of the following can be additional findings in this case, except what will not be an additional finding in this case. Make sure that you read the question properly. Make sure that you do not miss out on terms like all of the following except, because generally we, when we are reading questions very fast, we tend to skip out on these small little things hidden in the question. So all of the following can be additional findings in this case, except what is not a finding: primary amenorrhea, absent secondary sexual characteristics, normal karyotype, or hematometra. So you have to give me a diagnosis first. Yes, Peter, you are right in saying, and people who are attempting option number B are incorrect. Yes. Except, yes, very good. So option number B is the correct response. There will not be absence of secondary sexual characteristics, right? She has been brought with complaint of severe abdominal pain. Why is she having such severe abdominal pain? Because there has been blood which has been collecting inside for so many months, maybe, right? That is hematometra. Yes, so hematometra is there, and that collection will obviously begin to form in the vagina first. So there will be hematocolpos also, and in front of the vagina there's this urethra, right? So that bulge in that collection in the vagina is going to compress the urethra and can also lead to acute urinary retention, right? So hematometra, hematocolpos are going to be there. Tense bluish bulge at the introitus. Your diagnosis is made. This is imperforate hymen. This is imperforate hymen, right? And of course, because of the hymen being imperforated, that's primary amenorrhea. And there is nothing wrong with the karyotype of the young girl here. The karyotype is normal, but the ovaries are there present. So secondary sexual characteristics are going to be present, not absent. All right, present and not absent here. And she's not going to have an ovulatory cycle, Dr. Katari, Bindu. She's not going to have, an ovulatory cycles. She will have cycles just like anybody else who's having cycles in a 15-year-old girl. Initially in pubertal age, she might have some, a year or two of anovulatory cycles there, but ovulation will set in. So her puberty is progressing like anybody else's normal pubertal development she's having, except for the fact that the blood is not coming out. Okay, this is called as cryptomenorrhea, hidden menses. So that's her problem. If I ask you and form a question in this case, like, what is the next treatment? What is the treatment for this imperforate hymen? Anybody? Yes. What is the treatment for this imperforate hymen? What should be done? Should she be given hormones? Should she be given some surgical treatment? Should some advanced investigations be done? I mean, you can at least do an ultrasound if that is justified to see the amount of blood that has been collected, you see. An imperforate hymen will need to be treated by a simple incision. Very good, Peter and ED. Cruciate incision. Cruciate incision, an X-shaped incision given over the imperforate hymen, and let the contents drain, let the collected blood drain, and let the outflow open again. As simple as that. And the other thing, in this particular case, she's come with acute urinary retention. Don't forget to catheterize her. Okay, she was brought in with the complaint of acute urinary retention. Don't forget to catheterize her. And yes, of course, the final definitive treatment of imperforate hymen is giving a cruciate incision. Now, let's have a look at the approach to primary amenorrhea. Now, each of these approaches is very, very important. Okay, we'll go and deal with them one by one. That will make it easier. So whenever there is primary amenorrhea and breast development is present, that is what you should look at first. If they are asking you a question, primary amenorrhea, look what they are telling you, whether breast development is there or not. If breast development is present, look at what they are providing you information about. Are they telling you that the uterus is present? Okay, they could give you this information based on clinical examination findings, or there could be an ultrasound report showing uterus is present. And if there is a history of cryptomenorrhea, right, cyclical abdominal pain with no outflow of menses, maybe with some abdominal lump or something, think of two possibilities: imperforate hymen, I'll write in short form, okay, and a transverse vaginal septum. Imperforate hymen is a fairly simple clinical diagnosis. Local examination, you see a bluish bulge at the introitus. Sometimes maybe the collection is not enough to cause a bulge immediately, then ask the young girl to perform Valsalva or to cough. The bluish bulge will become apparent. So it's a very fairly simple clinical diagnosis. If that is not the diagnosis, think about the possibility of transverse vaginal septum. And in transverse vaginal septum, local examination, the orifice of the vagina looks normal, because most of the times the location of this transverse vaginal septum is in the upper part of the vagina. Well, it can be anywhere in the vagina, upper part, middle part, lower part of vagina, but most of the times it is going to be the upper part of the vagina. If they give you the information that the uterus is absent, then you consider two possible differential diagnoses: Mullerian agenesis and androgen insensitivity syndrome. We'll talk about these in the upcoming questions. And when the breast development is absent, what do you consider? We'll talk about in the upcoming sections. So go step by step: breast development present, uterus present, cryptomenorrhea history, two possible differential diagnosis. Uterus absent, consider two important differential diagnoses. Now, with this flowchart in your mind, which I just gave you, answer this question. A 14-year-old girl presents with primary amenorrhea, monthly lower abdominal pain. She's got good secondary sexual characteristics, axillary pubic hair are all there. Vaginal orifice is normal. Per abdominal examination reveals an abdominopelvic lump. On per rectal examination, a mass can be felt anterior to the rectum. In further workup, what's the best investigation to help the diagnosis? You have to tell me what's the best investigation. You will be able to answer it as far as what is the best investigation to confirm the diagnosis when you yourself know what is the diagnosis that you are suspecting to be most likely in this situation. So yes, history of cryptomenorrhea, breast development present, local examination, vaginal orifice present, but you all have all the evidence of collection of blood in the vagina and in the uterus. There is an abdominopelvic lump. There is some mass that you can feel anterior to the rectum on per rectal examination. So you are suspecting a transverse vaginal septum. Now your confusion is whether to choose between option number A or option number B. Now, I would say I could start with an ultrasound initially. There's no problem in that. It will help me at the most find out where the collection is. But if you want to be very certain about the diagnosis of transverse vaginal septum, an MRI is going to give you the best diagnosis. MRI is the modality in which, you know, the soft tissue delineation is very good. So if I want to look at how thick the septum is, how deep into the vagina the septum is, then most accurate information can be gained by MRI. Okay, so ultrasound can be your next investigation, but they're particularly asking you what is the best investigation to help you make the diagnosis. That's the only reason why I choose MRI. And yes, Peter is also adding to the explanation here. Peter is adding that this transverse vaginal septum could also be associated with other Mullerian anomalies. Very good. Could be associated with other Mullerian anomalies. Could also be associated with other renal tract abnormalities. So might as well go ahead with an MRI to give you the best shot at making the diagnosis with one investigation. So that's why we choose MRI in this answer. Transvaginal septum may not be an isolated abnormality. There can be other Mullerian anomalies associated with it. There could be a biconjugate uterus, there could be a uterus didelphys. You could make the diagnosis with MRI there. Now, let's have a look at the next question. Now, there is a 16-year-old girl who's being evaluated for primary amenorrhea. Breast development is normal and the uterus is absent. There is a blind vaginal pouch and the gonads are ovaries. What investigation should be done next? A hormonal profile, an MRI pelvis, a CT scan pelvis, or a gonadal biopsy? Yes. Breast development present, uterus absent, and a blind vaginal pouch. Only that part of the vagina, you see, that develops from the urogenital sinus, that remains. The part of the vagina developing from the Mullerian duct, that is absent. So it's probably Mullerian agenesis. Because I'm also saying Mullerian agenesis, why? Because they're giving me this information that the gonads are ovaries. The gonads are ovaries. So it's possibly Mullerian agenesis. That is my suspicion so far. Okay, when I told you uterus is absent, you consider two possibilities: androgen insensitivity syndrome and Mullerian agenesis. In Mullerian agenesis, the gonads are ovaries. Now, why would a hormonal profile help you? What will you find in hormonal profile? If you do a hormonal profile, but your hormones are going to be normal anyways. If breast development is happening, that is a very good sign that her hormone levels are all normal. That is why she is having breast development, which is normal. Okay, so your hormonal profile will give you no additional information. Hormones will be normal. Okay, gonadal biopsy, there's no reason to biopsy these ovaries. That is information is given to you, right? These are healthy ovaries in Mullerian agenesis. No need to biopsy them. Now, MRI and CT scan. Now, MRI pelvis is the investigation that you are going to do, not because you want to make a diagnosis, but because Mullerian agenesis can be associated with renal tract anomalies. Remember MRKH syndrome? Yes, Mullerian agenesis can be associated with Mayer-Rokitansky-Kuster-Hauser syndrome, where there can be vertebral abnormalities, hemivertebral scoliosis, there can be renal agenesis, there can be horseshoe kidney, there can be a urinary tract as well. So you need to evaluate women with Mullerian agenesis to see urinary anomalies associated with them, and therefore you should be doing an MRI pelvis at this point in. Now, Sadia, testosterone out whether or not it is androgen insensitivity syndrome. I can also go for a serum testosterone level here. They will be in the normal female range. Okay. Asked in the, that has not been provided to you in the options, but I agree with you that if the serum testosterone levels are in the normal range, and the karyotype in Mullerian agenesis is normal, insensitivity syndrome is, you would ultimately, you would go for that. You would also go for